Chip and the foundation for the invitation to speak to you all. I'm going to present about the Dutch cohort of DADA2 patients. So the Dutch cohort is actually a collaboration between a lot of clinical centers, all the Dutch university centers, as depicted there on the picture. So I'm grateful that they have collaborated, and I'm presenting on their behalf as well. We have also made use of PRINTO. So this is a European registry for other inflammatory diseases, and this is a thank you to Marco as well. Chip told me not to put an acknowledgement slide at the end, so I will just do it at the beginning. How did we go about to find all the DADA2 patients? We actually contacted all the genetic labs, all the immunology labs, all the physicians that we know are actually working in the field of DADA2. We contacted all these different institutes, and I'm pretty sure that we have found by that moment all the DADA2 patients in the Netherlands. So there were 32, and 29 of them provided informed consent. So 3 of them are missing. They are from 23 families. There are 5 sibling pairs in the cohort, and the follow-up was actually at that moment between 2 months and 10 years. And I also need to thank Valerie Andriessen, who was by that time a student. She now is a medical doctor, because she did most of the work for the cohort study. Now, what did we find after we had inventorized all the patients? The symptoms were, as we all know, mainly cutaneous. There was a lot of hepatosplenomegaly. There were recurrent infections in 60% of the patients. So those were the symptoms that we saw most frequently. The most predominant phenotype that we saw was the mixed phenotype. Afterwards came the vasculopathy phenotype, and 14% had hematological phenotype. No patients in the Netherlands had a single immunological phenotype. The genetics, at first when we started to study DADA2, we thought, or we knew that almost everybody in the Netherlands had the R169Q mutation, but by now only 34% of the patients have that same mutation, followed by this other well-known splice site mutation. The patients with the R169Q mutation have a mixed phenotype, and with the second mutation, the splice site mutation, mainly have a vasculopathy phenotype. But other than that, we could not find a real association between genotype and phenotype. If we look at the laboratory values, you can see any form of cytopenia in 72% of the patients at any time during follow-up for a longer period. So that is actually quite a high number, and you see the breakdown of that below. Hypogammaglobulinemia in the end was found in 50% of the patients, so also quite a high number, I guess. This slide shows medication and outcome of the patient cohort. 3 patients by now have undergone stem cell transplantation, and 2 are on the waiting list to undergo that procedure. 19% are currently on any type of TNF inhibition. 2 patients are by own choice not on any immune suppressive treatment. That scares us, but yeah, it happens in other countries as well, as I have learned in the recent days. And 5 patients actually have sadly passed away, and I will come to that later on in the presentation. This is the breakdown of the types of TNF inhibition that actually is prescribed currently. And what does it do? What is the follow-up on the outcome of the TNF inhibition? So here is a slide that shows clinical manifestations before and after the start of TNF inhibition. And what you see is actually it does quite well on the cutaneous symptoms of DADA2, except for the eczema. It works well for the fever. It seems to work very well for stroke. Although there were 2 patients that we had a suspicion of stroke. I will come to that later as well. It worked very good for PON-like rash or other types of cutaneous vasculitis. And it didn't work so well for the cytopenias. So any type of cytopenia that we saw responded very poorly on the TNF inhibition. This is all observed in other cohorts as well. Now, there were some symptoms that were actually quite, well, interesting or abnormal or a bit scary maybe. I'm not sure, I don't see the clock running, Chip, so I'll advance until you stand up, right? Yeah.
I didn't catch that.
Oh, I don't see the clock running, so I'm not sure where I are.
Just wave at you like this.
Yes, I will. Yeah. So what I'm going to talk about next is the genotype-phenotype correlation. We found a couple of cases with MAS, macrophage activation syndrome, HLH. We saw some patients with malignancies, and we saw some patients that actually had stroke while they were on TNF inhibition. And so I will come back now in a couple of slides on these cases. So this is a slide that actually shows the residual ADA2 enzyme activity in 18 of the patients that we were able to measure this in. And it is divided in the paper also by the genetic uptake of the patient. On the left, you see the normal range in one of the black bars, and the patient range in one of the black bars, and the carrier range is really in between in our lab. What Pew also already showed is that we seemed to see a bit more residual ADA2 enzyme activity in the patients that had a vasculopathy phenotype versus the patients that had the hematological phenotype. But this did not reach statistical significance at this moment. When we looked at ADA2 residual activity versus any other type of symptom, it did not reach any trend towards statistical significance. Now, this is the slide about the secondary hemophagocytosis. It's actually a lot of information, but I'll just try to walk you through it. What we see here is that there are 4 patients that have had one or more periods of MAS, macrophage activating syndrome. Here we see what their age was actually at the moment that they had this period. So there were 2 children. Oh no, this is the moment at which their DADA2 diagnosis was made. And here you see what the age was at which they had their HLH period. So you see that the boy, it was not known yet that he had DADA2. This girl, it was also not known yet that she had DADA2. And these 2 patients, the 2 older patients, it was only during the course of the MAS it became known that the diagnosis was actually DADA2. So what we learn here is that patients in their initial presentation may present with symptoms that are compatible with MAS. Their phenotype was mixed, hematological and mixed. So it's always difficult to diagnose those patients. Some of them had, or actually one patient had no symptoms of DADA2 before. And the other patient, as you can read here, they had already quite some symptoms, but they were not attributed to the suspicion of DADA2 by then. Obviously, none of them were on any type of TNF inhibition. And here is what happened in the 8-year-old boy. So he contracted EBV and he developed, thank you, 5 minutes, a period of HLH-like symptoms. But in his case, he had no treatment. It took a long time to clear the EBV, but his outcome was actually very good. And only afterwards we found out that he had DADA2. This 53-year-old man became quite ill, actually. So he had full-blown MAS. So he was treated with prednisone, anakinra. Afterwards, he was given the full HLH 2004 protocol and rituximab and JAK inhibition. And apparently, he became so immune suppressed that he passed away due to neutropenic septic shock. But there was no trigger known for the HLH. This patient developed angioimmunoblastic T-cell lymphoma, and afterwards, in the treatment with chemotherapy, contracted EBV or reactivated EBV. A lot of drugs were given actually to try to, how would you say it, to treat the HLH. He even underwent autologous SCT before, but he passed away after he became very thrombopenic and developed an intracerebral bleed. And the last patient here was a 9-year-old girl. She was being evaluated for recurrent infections, stomatitis, and optic neuritis, skin granulomatous disease. She became very ill with high fever, full-blown MAS picture. She was treated with methylprednisolone pulse, TNF inhibition, and then, of course, genetics were sent, and when the diagnosis became known that it was DADA2, it was actually already so late that 2 days later she passed away. And then we knew what actually was the case there. Now, this is the slide about the malignancies. Here you can see that there is, in the age range of mainly adult patients that there are malignancies reported here. This is their DADA2 phenotype. And here you see that there are actually quite mixed type of malignancies. So this man had prostate carcinoma. These two patients had basal cell carcinoma on the skin. So you could say, well, this can be treated, this can be cut out, this can happen at this age. But then there's 5 patients remaining that have actually a malignancy in their blood. So B-cell lymphoma, TLGL, and an AML diagnosis. And we wondered whether that had something to do with the DADA2 diagnosis, but we are unclear there. And this is what the outcomes is of those patients. They actually most of them did quite well. If we focus on the neurological manifestations, we focused on manifestations before and after start of TNF inhibition. And Femke de Klauwer, who is an adult neurologist, contacted all the physicians, went through all the charts, so they really took an in-depth investigation. Here you can see that neurological manifestations at the onset of the disease or at presentation were already quite frequent. So this is at at onset. I'm sorry, I need to go back here. And here you can see that there was no relation between the residual amount of ADA2 enzyme activity between the patients without neurological manifestations and the patients with neurological manifestations. 2 minutes, thank you. What does TNF inhibition do for the neurological manifestation? Actually, it works quite good. So here you can see that TIA and ischemic stroke actually was present in the whole cohort in 41% of patients, and it nearly never came back after the start of TNF inhibition. For other neurological symptoms like headache, vertigo, ataxia, we saw a steep decline in the episodes with these neurological complaints or symptoms, but it didn't go all the way. And here for the periods with any type of cranial nerve deficit, they were quite often before the start of TNF inhibition, and they were very rare afterwards. Now, we couldn't predict which patient was going to develop a stroke. The only thing that came back statistically significant here was the fact that a lot of the patients who in the end developed stroke also had pen-like rash, but any of the other symptoms was not correlated to the development of stroke. Now, as I said, 2 patients seemed to have developed stroke even under the treatment with TNF inhibition. The first one was a 50-year-old patient who was actually very difficult to treat. His main phenotype was that he had very difficult skin ulcers, the PAN phenotype. He was treated with adalimumab, and then he was switched to infliximab, and 2 months after that, he developed stroke in the posterior region of his brain. We thought it might have been therapy failure because he still had active skin disease also in the months after that he had developed this stroke. He also was switched to golimumab. We couldn't control him with that, and he is now on JAK inhibition, and he's actually doing quite well with that type of drug. And the other patient is a 59-year-old patient who had the clinical symptoms that were fully compatible with minor stroke. But on day 1, after this episode, we did an MRI and we couldn't find anything. The symptoms lasted so long that they were not compatible with TIA anymore. Actually, the patient still has some residual symptoms of that episode, but only very mild. We found aneurysmatic disease in 1 patient. I guess the time's almost up. So this patient actually presented with a subarachnoidal bleed, and we found that this patient also had visceral aneurysms in the abdomen. So that was not reported before to our knowledge, so we thought that was something to mention again, as well in the paper. To conclude, we also do our 1 or 2 yearly patient days, highly appreciated by the patients, just sitting them in a room like we sit in the same room and discussing what is the disease, what is the treatment, what are future development, apparently highly appreciated. So in conclusion, we found that a higher residual ADA2 enzyme activity is possibly related to the vasculopathic phenotype, as was suggested before. We report several cases with MAS and malignancies, and yeah, for the type of treatment that was given for those diseases, I think we need urgent guidance on how to treat it actually. Neurological symptoms were seen very frequently, and TNF, yeah, I struggled with this phase. It prevents stroke, but in stable patients. So if a patient is really not stable, then I'm not sure if it can really always present stroke. Thank you for your attention.
All right, well, Joris, thank you. And you can, so thank you very much. We have, I think, a couple minutes. You can stay up here, a couple minutes for you to answer questions. If there are questions from the group. Yes, please, Marco.
Thank you very much. Very interesting. Two things. Did you check for antibodies against infliximab in this patient? Can you suggest maybe to use methotrexate in combination if you suspect that there is inefficient efficacy of the anti-TNF? Second point is very interesting that we see in a couple of patients also HLH. That is indeed part of the manifestation. I noticed also for our patient that all these patients that enter in the HLH were not on treatment with anti-TNF. That also is your case. So that means that is another, and sometimes was the first signs. So this is very interesting also to in our discussion on how, if treat or not to treat patients with severe mutation that are completely asymptomatic, because they are prone to develop a severe mass if they are in fact inflamed. I would like to have your opinion on that.
Yeah, so I fully agree that we must counsel them that TNF inhibition works to prevent stroke, but maybe we need more research, but maybe we should also counsel them that it can help prevent MAS/HLH. So that's a very good point, I guess. As for the other question, were there anti-drug antibodies? In the two patients that had stroke or minor stroke, there were no anti-drug antibodies. But in the whole cohort, not all of the patients were at the moment or are being treated with methotrexate or leflunomide. So 4 of the patients are actually, and the rest is not. So we need to present the guideline even more. Yeah.
Other questions from the group? Yes, please, Paul.
Thanks, Doris. Just 2 points. Like us, I noticed the majority of your patients were on adalimumab. That's what we did in the UK. I regret that now. I wish we'd started with etanercept because it's less immunogenic, and we're seeing more and more patients developing anti-drug antibodies. So I wish we'd started with etanercept. Like you, we've got a few patients that give me heart attacks by saying they don't want to start any anti-TNF. They'd rather wait for when they need it, even though they fully understand. So it's somewhat reassuring to hear that we're not the only ones. Mm-hmm. And then the cancer thing I think is interesting because we're learning that all humans make lots of cancerous mutations, but it's when you have inflammation, that's the second hit. So in the lung, we're making mutations all the time. So I'm really unsurprised that DADA2 patients may have more hematological malignancy. I think we all make mutations in our hematological cells, but when you have a lifelong autoinflammation in addition, I think that's the second hit. So I think it's very plausible, your observation.
Yeah, and do you also suggest that we should screen them, or because if I ask to our oncology team or the radiology team, then they say, well, there's no way to screen them on a 6-month basis that is actually useful. So when it happens, and then you will need to diagnose it.
Well, I mean, I'm not an expert on cancer screening, you know, but these are patients who are having regular full blood counts and blood films. When things change, maybe we should have a lower threshold for looking for, you know, cancers, hematological blood films, marrow, you know, whole body MRI, that sort of thing.
Yeah, yeah. And as for your suggestion for the infliximab, so we were discussing a couple of days ago also a woman, and she was she had questions about getting pregnant, etc. So there, the infliximab is also obviously maybe a better choice because you're not on. So the methotrexate or the leflunomide is not necessary. So yeah, it would have an advantage there as well.